You're up.
Smile.
So this is the last lecture, okay? And I mean, I think that everybody that's grin and bear through this, I think hopefully this has been educational and helpful in terms of, you know, people walking away with this and learning something new, right? And I think more importantly, I think you all deserve a lot of credit for doing this. And I think it's good that we've done this to separate us away from hopefully the other units in terms of the nurses, and especially with moving to a new intensive care unit. I think this is a good thing that we've done together in preparation, you know, for that. So I thank you all. Thank you.
Thank you.
Thank you.
All right, so the last one we're going to talk about, all right, is special considerations. And this one's actually, I think, you know, pretty interesting. It's not as, you know, bland. It's a little mixture of little things, and we'll, you know, talk about this, you know, pretty quickly. So we're going to talk about pulmonary embolism, which I think is important in the environment in which we live. We'll talk a little bit about prophylaxis and the treatment of pulmonary embolism, the diagnosis and how we make that diagnosis. Then we're going to talk a little bit about GI hemorrhage, and then how we prophylax for stress gastritis in the ICU. And poisoning is not something really that we see a lot in the intensive care unit, but it's pretty straightforward in terms of how that's managed. Hypertensive crisis, kind of important, especially in the neurosurgical population that we take care of. Talk a little bit about that. And then finally, one which I think we're confronted with, you know, not infrequently, is that of intra-abdominal hypertension in an abdominal compartment. And I think certainly, you know, nursing from a nursing perspective can really be involved, right, in driving this and bringing it to, you know, the residents' attention or to the attendees' attention or anybody's attention that this is developing. Okay, so that's kind of what we're going to talk about here in 15, 20 minutes. So like always, it starts with a case study. So we got a relatively large gal, right? She's got a BMI of 40. She's a smoker. She's got heart failure, and she suddenly complains of shortness of breath, and she's got right pleuritic chest pain. Her vital signs are what you see, and her chest x-ray reportedly has no infiltrates on a chest radiograph, okay? So what risk factors do you think this gal has for possibly having a pulmonary embolus?
Obesity, tobacco use, heart failure.
Good.
And
okay, so good. So if you think about the patients that we have in the ICU right now, right? So we try to, you know, we always generally provide DVT prophylaxis in one way or the other. There's certain patient population that sometimes that we can't use, you know, an anticoagulant, but usually we can use pneumatic compressors, right? But what patient in the ICU that we have right now that you think is at very high risk for having DVT and a PE? Out of all the patients that are here, which one? Six, right? Good. 6. He's badly injured, decelerating injury, you know, he's bedridden, he's a relatively large guy, had pins in both femurs, he was in traction, he's got, you know, bilateral acetabular fractures, so he's at high risk for deep venous thrombosis and pulmonary embolus. Yes, I agree, you know, and we're treating him the best we can do. We're treating him with, what are we doing? With Lovenox, right now Lovenox. Okay, so good. So I think it's important to identify patients that are high risk for deep venous thrombosis and pulmonary embolism, and most importantly, we'll talk a little bit about the treatment. So this is the workup, right? So you think somebody has a pulmonary embolism, so, you know, it's the usual chest x-ray, EKG, and you get an arterial blood gas, okay? So, and here's what the chest x-ray actually shows. And this is an interesting chest x-ray because generally if somebody has a pulmonary embolism, right, the chest x-ray should look relatively clear. But unfortunately in the environment where we live, you know, our patients generally are sick. They got a lot of other things that are going on, and chest x-rays generally are not normal, you know, in a surgical intensive care unit, you know, and some of that's attributed to A, because of their volume status, B, some of that's attributed to the fact that their body size, and more importantly, it's attributed to how the x-ray is taken, because the x-ray is taken differently, right? And, you know, it can be over-penetrated, under-penetrated, you know, the tube, when you take a chest x-ray, really patient should be in a sitting position, the tube should be 6 foot away from the patient when you're doing a chest x-ray in the ICU, but sometimes that doesn't happen. So it's hard sometimes to interpret a chest x-ray. But the workup, of course, if you have a patient who desaturates in the ICU, who you have a high suspicion that has had maybe a pulmonary embolism, the first place you start with the chest x-ray. And the interesting thing on this chest x-ray is that you can see that it looks like he's got a haziness in the right side of his chest, which he probably has a pleural effusion, but he also has this, okay? And this is interesting because this is one of the physical findings that you will see in a patient who has a pulmonary embolism, you could see. It's rare, but you can see it. This is called a Hampton's hump.
Hampton's hump?
It's called a Hampton's hump, right? See like a hump that comes off from the chest wall? And what this is from a pulmonary embolism in infarcted lung, right? So this is a piece of lung that's infarcted, right? So patients, A, they get an infarcted lung, B, they get pleuritic chest pain as a result of that. That's why they get chest pain, right? Because of the infarct that they have from the lung. And this is the radiographic appearance that you will find, which is rare, but you can see it. This is one of the diagnostic, findings of a patient with pulmonary embolism, again, on a routine chest x-ray, okay? But I can tell you, in my lifetime, maybe I've seen this once, maybe twice. So it's not something that's commonly seen, okay? So what diagnosis? So we have a patient who we have a high index of suspicion. So we got a patient in the ICU who, desaturates, tachycardic, hemodynamically unstable, and so a large net is cast. We go, okay, what could this be? It could be myocardial infarction, pulmonary embolism, worsening sepsis, so we're going through this drill. So what diagnostic steps, or what do we usually do? What do we send? ABG, right? So chest x-ray we talked about, and we get an arterial blood gas. So what would you expect the arterial blood gas to show you in a patient who's had a significant pulmonary embolism that has hemodynamic instability? What would you expect that blood gas to show? So you'd expect you expect an acidosis. So what happens? You would expect the PO2 to be low, right? The PCO2 you would expect to be high. No, right? So what happens when somebody has a pulmonary embolism and they get acutely hypoxic, right? They get tachypneic, right? They're tachypneic. So when you send a blood gas, right, then you're going to see a patient who has a respiratory alkalosis, right? So they'll have a respiratory alkalosis and they'll have hypoxia. That's the more common finding you find in arterial blood gas. Okay. So, once we have a suspicion the patient's had a pulmonary embolism, not to cut to the chase, but the most common tests that we do to rule out pulmonary embolism is what? So, interesting. So D-dimer is mentioned here. D-dimers are not routinely sent here because most patients that are hospital patients admitted to the hospital have critical illness in the ICU have elevated D-dimers, right? So D-dimer may not be particularly very helpful in the patient population that we care for. So it's a clinical scenario, high index of suspicion, and then what test do we get? We get a CT, right? So we get a CTA of the chest, right? To rule out pulmonary embolism. Now, CTAs of the chest show you the big pulmonary emboli, right? It doesn't show you the small ones, but it certainly shows you the big ones, and those are the ones that we really worry about, okay? So you get a CTA of the chest. Years ago, as what's depicted in this slide, you see it says VQ scans. We do very few VQ scans anymore, which is a ventilation perfusion scan. It's a radionuclear, test that's done in nuclear medicine, better known as what I call as unclear medicine, right? Because whenever you do a VQ scan, it has to be usually a 6-viewed study. It has to be ventilation and perfusion for you to be able to interpret that study. And more importantly, you have to have the clinician who's asking for that test has to have an opinion. And what I mean by opinion is that either I have to have a high index of suspicion, I have to have an intermediate index of suspicion, or I have to have a low index of suspicion. So when they get this test, you go to the radiologist in turn would say to you, what's your index of suspicion? So you can tell that the sensitivity of this test is because what you may think is high, I may say it's low, right? And all these things impact in terms of how that test really is determined. And again, we have to do ventilation perfusion, and most of the patients really have to be cooperative. A lot of patients, are sick from their critical illness, they're intubated on a ventilator. You can't do a ventilation scan because the isotope that they give, they got to inhale, and there's no system on a mechanically ventilated patient that you're able to do that on. So it's really a closed system of a mask on a patient. It's got to be cooperative, and it's hard to do. So usually what we used to do years gone by is that we get a 6-view perfusion scan, and depending on what our index of suspicion is, we'd say, if I had a high index of suspicion and a perfusion scan positive, I'd say pulmonary embolism, we'll treat the patient. Or if I thought the patient was high risk, and still was high risk for treatment, that being heparin or anticoagulation, then we would do a pulmonary angiogram where we put a catheter on the right. Let's say that the perfusion scan had a high index suspicion on the right, then I'd start with a pulmonary angiogram in the right pulmonary artery. And I wouldn't necessarily do the left. If we did the right and that's positive, we were done. Do you understand? And then we would go on, into treatment. But we don't do many pulmonary angiograms, which is the gold standard for the diagnosis of pulmonary embolism since the invention of CT scan. And CT scan has gotten much better in terms of its resolution and its speed and ability to make this diagnosis. So all of these patients generally get CTAs of the chest, and pulmonary angiography is not done much anymore. So what about a lower extremity duplex? How does that work out in somebody who has a pulmonary embolism? If you have a lower extremity duplex and if it's negative, does that rule out pulmonary embolism?
No.
Why not?
Because the clots can be above, yeah.
Okay,
And
so
trouble,
the answer
right?
is right. So 90 usually what's been reported in the literature over the years is more than 90% of blood clots come from the lower extremities. But now because of other devices we use, because of things that were put into place, that 10% of those can come from the upper extremity. So a lower extremity duplex does not rule out a pulmonary embolism, and more importantly, I could have a big clot in my common femoral vein. I could throw all that clot, have a big pulmonary embolism, do a lower extremity duplex, and it's negative because the clot's gone, right? The only way that's helpful, if I have a positive lower extremity duplex, right? Then and if I have a high index of suspicion the patient's had a pulmonary embolism, I'm going to treat that patient as if they've had a PE, right? Because usually lower extremity, if you have a lower extremity DVT, the treatment for that's in 3 months. A pulmonary embolism treatment usually is 6 months. You treat those patients. So there is a difference, right? But a lower extremity duplex, we surveil patients with lower extremity duplexes because we try to find them before patients have pulmonary embolism, so we provide them with treatment. All right, so we know about her presentation. We see the probability of a pulmonary embolism in this patient we thought was pretty high given her risk factors. And now we're to the D-dimer. We talked about D-dimer already. It's not really used, much in a hospital. And here in this algorithm, or in this, cartoon, the slide that you see here. So if you have a moderately high probability, we're going to go straight to a multi-detector CT scan, and if it's positive, then we're going to treat the pulmonary embolism, right? Okay. The PE is excluded. Then good. So negative CT, and then this is telling you VQ or leg duplex is normal, right? But the big thing here is a negative CT scan, which is really what pretty much the standard is that we're using for confirmed diagnosis. Okay. Here's just one image of a CT with a patient who's had a massive, pulmonary embolism, almost a saddle embolus from the right to the left. You see clot here, and clot over here. Okay. That's how it would appear on a CT scan. This is intravenous contrast in the cava, where it comes up from the atrium, and then you see it branch into the right pulmonary artery and left pulmonary artery, and you see the clot sitting right there. Okay. So what's the treatment? So treatment for these patients is an anticoagulant. We're going to anticoagulate the patient, usually with intravenous heparin. So if you have a patient who's had a pulmonary embolism and can be anticoagulated without, with very low risk, and that's what we do. What do we do if we have a patient who has a pulmonary embolism who I can't anticoagulate? They got a large intracerebral hematoma, or they got a big perinephric hematoma, or they got, they got some big reason why I can't anticoagulate them. Then what do we do? What do we do? So it's the first pulmonary embolism is usually the embolus that doesn't kill you, right? Kill your patient. It's the second one, right? So in this circumstance, if I am unable to anticoagulate the patient, then that patient would get their filter. They'd get a vena cava filter, all right, to protect them from another pulmonary embolism. Okay. There are other treatments for PE, especially if you have a patient who has a massive pulmonary embolism, a saddle embolus that's sitting both in the right and left main pulmonary artery, and the patient has hemodynamic instability, and those patients can be treated, as long as there's no risk, with a thrombolytic like TPA. You give them TPA to dissolve the clot. There are other things that are available in terms of extracting these clots. years ago, and it's not uncommon that even today that sometimes a patient's got a massive pulmonary embolism, they go to the operating room or put on cardiac bypass, and they get the thing extracted, operatively, in the operating room, which is a big operation, and generally those patients don't do very well when they do that, right? But nowadays it's usually with a clot buster like TPA, as long as the patient has no risk. Sometimes we've taken care of patients here post-operatively. There's one lady in particular in the last couple of years had a massive pulmonary embolism that was post-op. We gave her TPA, right? The good news is that she survived a pulmonary embolus, but she had a massive hemoperitoneum, and she bled from a TPA and had an open abdomen and was sick here for a long extended period of time, but ultimately ended up doing okay and walked out of the hospital, right? So you got to weigh your risk benefits in terms of how that's happened. We prophylax patients, right? So all these patients in the intensive care unit are relatively high risk patients for deep venous thrombosis and potential pulmonary embolism. So we prophylax them with what? With heparin, heparin or Lovenox, and what else do we use? Venodyne boots. Good. So how does Venodyne boots work? You're all putting Venodyne boots on patients all the time. How's that work? How does the Venodyne boot work? Okay, good. So your calf muscles, right, are the pumps of your lower extremities, right? They're kind of the heart pumps of your lower extremities that pumps blood back up, and prevents stasis. And we do that by walking. Your calf muscles are doing this. But when you're in bed and you're immobile, the pumps aren't pumping, then you get stasis, right? So then you get stasis, you get deep venous thrombosis, and then that leads the patient at risk for developing a pulmonary embolism, right? So so the Venodyne boots, they squeeze the calves, but do they do anything else? They do more than just squeeze the calves. That's why if you look at this, you read a little bit about this, you'll find that sometimes just squeezing one extremity, one upper extremity, or one extremity is helpful because actually it increases fibrinolysis or thromboxane, which is anticoagulant. So by squeezing muscle, it releases, certain substances that makes patients less likely to clot. All right, so Venodynes work in two different ways. One, by pumping blood, like what you said, and two, by fibrinolysis, by releasing thromboxane and preventing patients from doing that. So that's why sometimes it's beneficial from just squeezing one extremity as opposed to both extremities. Okay, because sometimes you'll see patient's got a tib-fib fracture, but we put a Venodyne boot on one side, not on the other side, right? So that's why. Okay, important to know. We talked about prophylaxis. We talked about what we use. There are other drugs and more fancier drugs that doesn't really have a lot of role in the surgical intensive care unit with the 10A inhibitors, Apixaban, those type drugs are sexy drugs. You don't have to follow INRs, but sometimes you get into trouble when patients bleed, and you're like, and not a lot of reversal agents for some of these 10A inhibitors that we have. Coumadin, of course, and we talked about the pneumatic compressor devices. Okay, quickly, just talk about upper GI bleeding. So you got a guy who comes in, he's got nausea, vomiting, bright red blood, he's pale tachycardic, he's hypotensive, and he's got a hematocrit of 28. Right? How would you prioritize interventions in a patient like this that's got a GI bleed? So what would we do? So we assess the patient, we try to determine whether it's an upper, whether it's a lower GI bleed, right? What does melena mean? You have a patient who gets melena, what does that mean?
Lower.
Upper or lower?
Lower.
Upper.
No?
Melena, upper.
Oh.
It's digestive blood.
Oh, that's right.
Upper. Melena is upper. Right? So if you have someone who's got melena, generally that's an upper GI bleed, right? Okay, so A, you're going to assess, B, we're going to resuscitate. So that usually means 2 big, large bore IVs if they're actively bleeding. And then we look at diagnostic therapeutic interventions and then the continued care that goes after that, right? So when we're assessing somebody with GI hemorrhage, always the only other problem that we have, it's airway, breathing, circulation. So if I have somebody who's in shock, who's hemorrhagic shock, what I say is, that's it. We're going to sedate the patient. I'm going to intubate the patient. I'm not going to worry about the airway, because we got a patient that's unstable. So that's what we're going to do, right? So you assess the airway. Volume status is very important. We evaluate volume status by a number of ways. A, by physical exam, B, by other maneuvers, blood pressure, arterial line, pulse variation, central venous pressure, ultrasound. There's a lot of different ways, you know, invasive and non-invasive ways that we can assess, you know, volume status. Also, we can assess volume status by certain blood works, right? What blood work do we use to assess volume status?
H and H.
H and H. What else?
Lactic.
Lactic acid. Good. Right. What else? Blood gas. Right.
Blood gas.
Metabolic acidosis, lactic acid. All these are things that we look at when we're resuscitating patients to decide whether we're getting better or we're getting worse. But here I'm saying there are other ways that we can assess our volume status by saying, worsening metabolic acidosis, right? Increasing lactic acid level, right? Which goes along with physical exam. Pale. So you put this all together and you say, boom, right? This is what it is, right? And then we put a naso or oral gastric tube in. Now we put a nasogastric tube in or oral gastric tube in. What are we looking for? We're looking for blood in the stomach. So we put an NG tube in. We find there's blood in the stomach. Boom, we're done. Want to put an NG tube in, we get bile.
That's not the
Unlikely.
problem.
Right? Then you're going to say this is either it's distal to the pylorus or it's you know distal, you know mid distal small bowel coming from the colon, right? But bile in the NG tube pretty much eliminates the potential possibility of some upper GI bleeding. What happens if you put an NG tube and you get back nothing? No bile, no nothing.
You wrong back.
That's right. Doesn't mean anything, right? You still have the patient can still be bleeding. You just don't know, right? So NG tube sometimes is diagnostic and sometimes therapeutic, right? So what factors suggest a severe GI bleed? We talked about those a little bit, right? Here we hear. Consider intubation, venous access, fluid administration, and then transfusion of red blood cells. And depends. Sometimes we call for the massive transfusion protocol. We get to level 1, hook up the machine, and we're resuscitating the patient, right? So what are the therapeutic interventions? Pretty straightforward, right? So we usually do an upper endoscopy, right? To see if we see anything is bleeding. If we see something is bleeding, then the endoscopist can either offer the patient an injection of epinephrine, they can put a clip on it, they can cauterize it. There's other things they can do. They look at the ulcer and they see something is bleeding, they can try and turn it off, right? Interventional radiology, if that doesn't work, then you see what we do. We put them in the elevator, we take them down to interventional radiology, and we look about doing an angio-embo. We can see something is actively bleeding, we can do an angio-embo and turn it off, right? Of course, if the coagulopathic, we're going to correct the coagulopathy, and obviously if endoscopy doesn't work, if IR doesn't work, then they go to the operating room, right? So you need some surgical assessment and some surgical on standby to decide when enough is enough and this patient actually needs to be taken to the operating room. Now, very quickly, one thing that's changed in my lifetime, which hasn't changed in your lifetime, is that I grew up in a time where there were no H2 blockers and there were no proton pump inhibitors. All I had was Maalox, Mylanta, and Amphigyl. There was nothing else, right? So, and years ago, when we didn't really understand volume resuscitation, I had patients in the ICU that were really sick, critically sick, that had upper GI bleeds, and those patients were taken to the operating room and had total gastrectomies. Their stomachs were taken out. And all those patients generally died, because that's a huge operation in somebody who's already critically ill. But we took out a lot of stomachs 25, 30 years ago. A lot of stomachs came out because of GI bleeding. Now, there's a number of things that have now changed that, and you don't see that disease anymore in our lifetime, or that disease has been pretty much almost not completely eliminated, but it's been significantly reduced. And a lot of that's because, one, we have better understanding of actually volume resuscitation. What helped them with that, optimizing cardiac output, was the Swan-Ganz catheter in years gone by to understand adequate volume resuscitation, because the stomach's like any other organ. If the stomach was underperfused, didn't have adequate perfusion, the lining is sloughed, they bled, their stomach got taken out, right? So now we have a better understanding of volume resuscitation, and two, we now have medications that we didn't have now. We have H2 blockers and we have proton pump inhibitors, right? So we have drugs now that we didn't have. So that disease itself really has kind of gone away in a lot of ways, right? Because we're a little bit smarter, about doing that. And a lower GI bleed managed differently, the answer is not really. Managed pretty much the same. You start from the top, work from the bottom. If they're stable, unstable, going back to what we talked about before, which was consider intubation, intravenous access, fluid administration, transfusion blood, find out what's bleeding and turn it off, right? Okay. So stress-related gastritis, who's at risk?
Nurse.
The nurses. Yeah, the nurses. So good. So you may hear us from time to time in the ICU. So there's things that are evidence-based medicine, you know, and there's, we usually say, is it type 1, type 2, type 3 evidence? Type 1 is that there is prospective randomized trials that